doctors nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
A colonoscopy, believe it or not, it's one of the greatest gifts you can give yourself to save your life. Colon cancer is one of the few cancers that are preventable. A colonoscopy without question can prevent cancer, and tell me how? We're going to find out. Suspicious polyps that are removed during the procedure can prevent any chances of having that polyp turn into a cancer. During this next hour, we have physicians answering questions about prevention, diagnosis, and treatment of colon cancer. And as you know, this is a live show, so if you have some questions of your own you want to think of and give us a call and ask, the number is 881-0013. We are also streaming live on YouTube and Instagram, so you can look up PBS El Paso and go to the El Paso Physician, and you'll be able to ask some questions there as well. This evening's program is underwritten by Texas Tech University Health Sciences Center and Dr. Richard McCollum. We also want to thank the El Paso County Medical Society for bringing the show to you each and every month. This is our 25th year. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. It's interesting because I'll have some of these doctors on the show, and yeah, they're doctors, but I've known them for 20 years. We've been doing this show for 20 years. You know, he talks about farts, and he talks about diarrhea, and he talks about all kinds of things that nobody wants to talk about. And that's what's great about the show, because you get to hear those things on the show and go, I'm not the only one. It's great. It's the El Paso Physician. So one of the docs you saw on that intro is Dr. Richard McCollum. He's been a big part of this program for many, many years. Again, we're going on 25 years, and he is known as the tummy doc. And today we have 3 gastroenterologists. And I remember the first time I did a gastroenterology show, I thought, my Lord, is that a word and a half to say? But we have with us Dr. Richard McCollum, who is, again, gastroenterologist, Dr. Alejandro Robles, gastroenterologist, and Dr. Sharif El-Hanafi, who's also a gastroenterologist. So these, all 3 have the same discipline, but they kind of work in the spaces in different areas. I know that you've been professor for quite some time and head of this and head of that. So if we could, Dr. McCollum, start off with just your background, just what you do here, talk about Texas Tech a little bit, what your role is there.
Well, I originally came, Catherine, as the chairman of medicine, brand new medical school in 2009, and also head of gastroenterology. Over time, I've evolved into a more research-directed physician, do a lot of work on gastrointestinal motility, as you know. Still do a lot of clinical care, look after patients, do endoscopies, and more or less look over and direct our research program.
And there's a lot of research to be done, because I know every time we do this program, there's something new on the horizon that's coming about, which is really interesting. We have some gadgets, toys, props to look into today too, which is kind of neat.
And help recruit the future. And you're
and you are the future.
We've had a great opportunity to recruit GI trainees who have become, and some have stayed, will stay as our GI fellows.
And
have
Sharif,
become
that's the perfect
GI
transition.
faculty.
Right.
Let me say, Catherine, to the audience out here, Catherine is just a great asset to the city of El Paso. She's done so much for us to teach us all about medicine and how to be involved with your own care and to advance the area. And we in the El Paso County Society, Medical Society, so much appreciate you, Catherine.
Thank you.
And I know the city needs to be aware of the many contributions you make every month.
Thank you. Man, you make me feel really good. Can you come every time we have a show? Dr. Sharif El-Hanafi, so I would love for you to talk a little bit about what you do all day, every day. Again, yes, we're in the world of gastroenterology. You are one of the newbies. You are one of the future, so to speak. But how would you describe what you do to the folks at home?
So I'm a gastroenterologist in Texas Tech, assistant professor and advanced endoscopy. I'm also the director of endoscopy and associate program director of fellowship, GI fellowship. I do endoscopy, general endoscopy, diagnostic endoscopy, and therapeutic endoscopy. I trained in advanced endoscopy. I see patients in clinic and office. I do clinical research, teach resident fellows and medical students.
Nice. I'm sorry, I'm trying to prep my phone really quick. For those of you that have been watching the show for several years, we used to have people run little questions to us on cards, but now we're getting all of our questions via the phone.
Nice.
So
Yeah,
I was just double checking and making sure that was the case. So my apologies for the noises
problem.
and the sounds that you hear. Dr. Alejandro Robles, and thank you again. You sent in some questions that we're going to be asking. I always like having some pre-questions to work from. But kind of the same question to a different person. Give us a background for the folks at home when they look at each one of you. What is it that they like to direct each way?
Okay, so I'm a gastroenterology fellow, so I'm in the process of undergoing and completing my training. I see patients in the hospital, patients in clinic. You know, I assist with the endoscopy, participate in research, and with education of residents and medical students. Yes.
Yes, and you're like, and that's it. But all encompassing now, and I'm going to start with Dr. McCollum because he's got the numbers. You have all the information and why we're having this show. I guess it's April, and I'll just let you take it from there.
Right, Colon Cancer Awareness Month was officially March, but we're very glad to be here with Catherine and you, the audience, and our experts, to tell you about a challenge that really, as I've come through gastroenterology, it's been a major, major challenge every year. We're now getting a little bit of a grip on it, but let me give you some of the numbers that are still concerning. Approximately 147,950 new cases of colorectal cancer are being diagnosed in 2021 in the United States, and 53,000 patients have died from colorectal cancer. The incidence of colorectal cancer in the United States is 25% higher in men than women, 20% higher in African Americans than in whites, and the death rates are also higher, about 40% or so in African Americans compared to whites. Our colleagues will tell you about the Hispanic population, and there are differences there as well, concerning differences, which make it all the more relevant to promote and advocate screening in El Paso.
And you were talking about screening too right before the show had started, and there's screening, El Paso screening, and then screening in America, and then screening around the world. But in general, where do we sit when it comes to that?
Well, the National Colorectal Cancer Roundtable has set the standard at 80% of our target population need to be screened. That's a pretty tall order. You always aim too high. We're not there. But around the country, we may be getting close to 65% or so. Here in El Paso, we're less than that. We're more in the 50s. So again, work to be done.
Right. Work to be done. And I don't know if we want to talk about it now. Actually, I do want to talk about it now because I don't want the show to go away and we haven't addressed it. What I'd like to do right now is talk about the prep. You were talking, actually every time we do this program, that is what patients come to you. It's like, oh, what about the prep? And they're scared of the prep because they don't know what the prep is. So let's talk about, we joked about the word cleansing, right?
Cleansing,
let's talk about cleansing the colon so that there are good images and we can really see what's going on inside. So explain that process. It's a little bit different. You know, there's 2 or 3 different ways of doing it, but.
Well, the reputation is that you're asked to drink a gallon of this very powerful laxative on the afternoon and the evening before your procedure. And it's pretty daunting. And we have some older folks in particular who have a lot of trouble keeping up with that schedule. So I try to tone it down. I try to make it more pleasant. When I get a colonoscopy, I start fasting 2 days before my procedure.
Smart.
I don't want much in my colon. So the last night, when I have to cleanse it, very little remains. So I drink Ensure, Gatorade, soup, and 2 days in a row by Thursday night, if I get it done Friday, I just drink a little bit of that 1 gallon jar. My stools are clean and water-like, and I can stop and go to bed and be prepared. So there are other techniques, but in general, we do not promote eating up to the last minute.
Right,
We promote
exactly.
fasting, minimizing solid food intake, drinking liquids, Ensure, Gatorade, water, and trying to minimize the trouble you go through the night before. Just drink a little bit of that stuff called Go Lightly, and you'll have a very pleasant experience.
So on average, when you're eating a meal, and I know every system is different, when you're eating a meal, the 24 hours, you're talking about 2 days ahead of time. Usually if other prep, it's like, okay, 24 hours before, stop, start drinking. But for our bodies to process a meal, and I don't mean to be gross, but that particular meal, I'm not talking about the meal before or what you had earlier, the meal that I'm eating right now, and let's say it's 7:10, when, for the most part, will that meal leave my body? And I know it's different for everyone. I know there's stuff left in there, but say you finished your colonoscopy, haven't eaten anything now in 2.5 days. Now I eat a meal. How long, for the most part, will that meal take?
15 to 24 hours.
Okay. And that's something I don't think people understand, because they think, I eat, 2 hours later, stuff comes out, but that's from the whole day before. And I think that's kind of important for us to know how that works.
Okay.
Dr. El-Hafani, I would love for you, because we're still in the beginning of the show, and if we can look at using some camera work here, you brought a really cool colon with you, for the lack of a better word. And I would love for you, as we see it on the screen right here, describe to the people at home what happens when food starts going into the colon, and we're going to talk about cancers and polyps and all that good stuff, but it's nice to hear and understand what the process is.
I will use this pen.
Okay.
So colon is a part of the digestive tract. It is called the large bowel. It is around 6 feet long. So here is the connection between the small intestine and large intestine. The food comes from the small intestine, goes to large intestine, and go all the way here up to the rectum and come out. So during this passage of food, the colon absorbs water. This is the main job of the colon: absorb water and absorb electrolyte and some nutrient. So it dry it up. Start very liquid and dry it up on the way out.
Okay.
So then the colon expel and push the remnant out, which
Okay.
called stool from the rectum. It is around 6 feet long tube, large tube, and this is what we call the colon.
Okay.
The main job of the colon is to absorb water and electrolytes.
So here's a question. I know it's off topic a little bit, but when people have diarrhea and there's a lot of liquid there, what is happening with the colon in that the colon is not able to absorb some water? For example, they ate something not so great, or they're ill in one way or the other. Just if you could just spend a little bit of time of why the colon doesn't always absorb water and what could be wrong or what could be the issue during that time.
If there is infection or inflammation in the colon, the mucosa and villi of the colon will be not working as should be. So it will not be absorbing water as should be. So there will be a lot of water remaining in the colon, and it has to come with the stool. So the stool will be like diarrhea.
Okay.
And there is many reasons for diarrhea: infection or inflammation, or sometimes cancer, or food, some certain type of food which is rich with osmolarity, which can pass to the colon and keep the water in the colon.
And for some reason your colon's not liking what's going on. So let's
Exactly.
take that same question opposite and talk about when there's not enough water, when there's constipation, for example.
Absolutely.
And again, I don't want to spend a lot of time on this, but I think
Sure.
everybody's curious, so let's
Yes.
ask the question.
Yes, constipation is the opposite of diarrhea. When you have solid stool, hard stool, or you are not passing stool every day or every other day. So constipation, your stool is dry.
Right.
So you don't have enough water in the stool, or your colon is not moving enough to push the stool out. So you don't have more fibers, or you don't eat a lot of fibers. So your stool is dry and not moving adequately in your colon. So it is the opposite of diarrhea, and many people complain of constipation. Also, if there is obstruction, if there is cancer, there can cause constipation or stricture or diverticulosis. There is a lot of condition can cause constipation. And Dr. McCallum is expert in the motility of the colon. So it is one of the reason can cause constipation as well.
See, and Dr. McCallum knows that we're going to get those questions anyway. Might as well get them out of the park in the beginning. So, Dr. Robles, let's go to screenings. And we talked a little bit about PrEP here, but when should someone start getting a screening? I know there's been a bit of a change. For many years, it's been start at 50. Now it's starting at 45, which is great. But let's talk a little bit about that and why the screening age has changed.
Sure. So I mean, it is great. You know, as Dr. McCallum spoke, you know, colon cancer, it's the third most common cause of cancer, cause and mortality. So screening works. You know, year after year, screening rates have been going up. Mortality incident rates have been going down. It gives us great evidence that it works. But when we look at the incidence of cancer, we kind of break it down into specific groups. You know, maybe those less than 50 years of age. We've noticed that actually colon cancer is actually going up on a yearly basis by about 2%.
Wow,
and when we look at
that's a
ages
lot.
between 50 to 64, colon cancer is going up by about 1% on a yearly basis. So this drop in cancer is mostly driven by those ages between 65 and 75 who are seeing a steeper decrease. Great news, excellent news for them, but this kind of gives us more evidence that, you know what, we need to start screening earlier.
Right.
Now, why is there earlier onset colon cancer? We're still not sure. We have some theories. Could it be more higher rates of obesity, higher rates of diabetes? We're not sure, but we hope that by decreasing the screening age, we can save more lives because we know it works.
And we have terrible diets. You
And
know,
we have
so
terrible
paying
diets,
attention
yes.
to diet would be one of those things too.
One of the good news, Dr. Roberts could add, is that the early cancer, 45 to 50 maybe, is more reachable, right? It's
That
more
is correct. That is
likely on what's called the left side, which he can show you on the diagram.
That is correct. So early onset colon cancer is what we call mostly on the left side. What is the left side? It's pretty much the last
This is
one-third.
perfect. I remember us talking about this last time. And
Yes.
why is it on the left side?
So we're still not sure. You know, it's a very
Okay,
good
so
question,
if we
but
could- yeah.
it's more on the left side, more on the distal portion, on the last one-third part of the colon. It's way more reachable. You know, we talk about screening modalities, and one of the things we can do is what we call a flexible sigmoidoscopy. Instead of just doing a whole colonoscopy, we can just take a look into this area and be able to count that as screening for these individuals. So
Okay,
yes.
because chances are if there is something off, it'll be there.
That's correct.
On that note, might this be a good time to look at what the scope does?
Yeah.
Okay, I say let's do it. Valeria is ready with the camera. And so take this scope, and again, I think knowledge is power, and knowledge helps fear go away.
Absolutely. So
Right. So we're gonna show people at home what the colonoscopy is.
So this is pretty much our scope that we use. You know, we has a little light, very bright light. We go in through the rectum, and we kind of maneuver our way through the colon until we get to the very far side. We can go up. It's opposite here, but we can go up, we can go down, we can go left, we can go right. This device here has the ability for us to pass little instruments that we find a polyp, we can remove it. Gives us ability to wash stuff off in case maybe the prep wasn't optimized. We can
right.
wash off, we can spray water, we can fill the colon with air so we can take a good look at the entire colon. So very, very fancy instrument. You know, great advances have been made with these things here. Yeah.
Right.
Yeah.
And in a few moments too, we'll get to it, but we're going to talk about the snips and the lassos
Right.
and all that good stuff. And let's, Dr. McCallum, we can go to that right away, actually. Doctor, I know this is where it gets kind of funny because Dr. El Hanafi is like, well, what about me? You know, where's the love? But we're going to get to that too. But since we just looked at the tool for colonoscopies, you have I think you call it something, the lasso, you have...
We have lassos. We have all kinds of toys here for our...
The lasso you do, yes, exactly.
So, you know, all these instruments can actually be passed through the scope to the area where we want to be in. So this is what we call a forceps. A little small. We use it to obtain samples from the colon, whether we want to make a diagnosis, we see inflammation. At the same time, we can remove small polyps. Maybe those polyps that measure from 2 to 3 millimeters. We can grab it, close it off, and literally just rip them off.
So I know that we're on television, it might be difficult to see,
put
but I'll
that
kind of
through?
explain what that looks
Put it
like.
through
Sure.
and show.
Yeah, that'd be
So
great.
very, very, I mean, tiny
It's like a
forceps.
claw, a
Yeah.
metal
Go ahead.
claw, and when the scope goes through and sees a polyp, the claw is then able to go around the polyp and pretty much clip it off, just like nail clippers. If you
Pretty
were-
much. So we pretty much just, you know, we got these things here through here. Do you want to grab this right here, Dr. McCallum?
Will be your technician.
Or Dr. Hanafi will be our technician. So we typically always have, we have excellent nurses that we work with up in the endoscopy unit, excellent endoscopy techs who pretty much all help us be able to perform these procedures here. So as you can see now, it's coming out. So as we maneuver through the colon, we find a polyp, or we need to take a sample. Maybe, unfortunately, let's say there's a tumor there. We need to make a diagnosis before we can say what it is and be able to provide treatment. So we get this there. We open up the forceps. We can get a piece of sample, and after that, we just pull it back. And we can open it.
Right.
There we go.
Yeah.
There you go.
And we can take a nice piece of tissue.
Nice piece
Take
of
a
tissue.
nice piece of tissue. Only a doctor would say that.
Yes.
I'm going to take a nice piece of tissue.
You won't feel it.
You won't feel a thing. No, but that's fascinating. And so we don't have to insert the other one, but there's another one that you
we
have.
can do it. We can do it.
But this is mainly for the small
You go
polyps.
ahead.
This is for the small polyps.
So that's
These are for
mainly
the small polyps.
That's
Yes.
mainly
Okay.
for the small polyps.
Gotcha.
Now here we have what we called our snare. So it's a little bit longer instrument in which we can kind of lasso polyps. We find a polyp. And, I mean, you see, I'm not sure you guys can see that there. It's like a little loop of a little wire. That once we're in the colon, we find a bigger polyps. We kind of just go around it. We get on top of it, and we can close it off. Now this can either be cold, meaning we just cut through it, or we can use heat, in which kind of cauterizes to prevent bleeding throughout the procedure.
Bingo.
So, yes,
That is so
yes.
important to say. I think people also, because I'd like to also debunk myths while we're here this evening. So a polyp is taken out, and you think, oh my goodness, they cut a polyp out of me. So how do I make sure that there's a small chance of bleeding, very tiny chance? Yes, Dr. McCollum, I can see your face going, hey, I got this one.
Yeah. Well, it's in the informed consent.
Yeah, right.
1 in 1,000 or whatever it is. But we have to be careful. Many patients are taking anticoagulants, aspirin, Motrin, and other things that might potentiate the chance of a little cut bleeding a bit. So we very carefully make sure we understand what our patients are doing and stopping any appropriate medications. But then otherwise, as Dr. Allen-Haffey will attest to, there are occasions when you take the polyp out, and we're concerned about a bit of leaking, a bit more blood, if you like, than we'd like. And so he has a technique, and others do, where you put a clip.
Exactly.
You put a clip through the endoscope,
Okay.
and you can essentially suture that little opening where the polyp was and stop any remote chance of bleeding.
Okay, so now you're on stage.
Yep.
Talk about you actually doing this with a patient. So the clip goes through the scope
Sure.
and kind of walk us through it from there.
Absolutely. So removing polyps is most of the time is safe, and the risk of bleeding is really low, around 1 in 1,000, especially in small polyps. And when we remove large polyp, we take our precaution. So if based on the risk if the patient is taking anticoagulation or taking aspirin, we try to close the area where we resect the polyp. We have multiple tools for that. The most common, we put clips, endoscopic clips, to clip the area and approximate the edges. To
And do the caps stay in the colon? Or is it something
yeah,
that they...
it goes with the stool.
Okay. Oh, it goes with the stool.
Yeah, 1 to
Perfect.
2 weeks, we go again, nothing's there.
So it's almost like a scab,
Yes.
for the lack of a better word. I'm trying to describe it for the audience. So it's like a scab. Once the scab finishes healing,
Exactly.
it falls off, and then it goes
4 or 5
bye-bye.
days.
You flush it down. It goes to the ocean, as Nemo would say.
So
Okay.
removing polyps is most of the time is safe and doable, and the endoscopy field has expanded a lot, and now we have a lot of tools to close either perforation or bleeding, to stop bleeding. So we have sutures. We can suture the area of if the defect is big and approximate the edges, or we use large clips to close it. But it doesn't happen a lot. It's 1 in 1,000, and most of the time colonoscopy is a safe screening method.
So bottom line is, have your colonoscopy, because it can save your life.
Exactly.
Big deal. And if for some reason there is a bleed, if you need to, very, very seldom, you can go back in and fix things. So that's
Exactly.
that's important for people to know.
It is most of the time it is fixable. Complication is rare, and we have a lot of tools to fix most of the
Nice.
complication.
Okay, excellent. I want to talk about types of screening tests. We're talking about colonoscopy right now. But I know there's Cologuard. I know that there are several different types of tests, and I want to kind of get that out of the way because we see advertisements, it's television, magazines, et cetera, et cetera. And I don't know who wants to take that. Dr. McCollum, I'll go with you. Dr.
Well,
Robles.
let Dr. Robles
Dr.
handle that
Robles,
one.
there you go. It's on you, buddy.
Yeah, sure. So there's definitely a lot of different kinds of testing that we can do for screening. And we usually decide upon this after discussing it with the patients, kind of discussing the pros and cons of each. There's stool tests. There's one that's called the fecal occult blood test, FOBT, which they provide a sample of stool. We put a chemical looking for any signs of blood. Now, if there's any blood, we're concerned there might be something that's bleeding, like a tumor or a big polyp. There's a test called the FIT, fecal immunochemical testing, which very similar to the FOBT, but here we use antibodies to check for blood. Now, this Cologuard is what we call the stool DNA test. It's actually a combination of tests. It actually involves the FIT test, which is the antibodies. In addition to that, we're also looking for altered DNA. Altered DNA meaning DNA from cancer cells. Cells. So most of these tests are performed on a yearly basis, except for the DNA test. FIT DNA test, which is performed every 3 years.
Okay.
And of course, we have our colonoscope here, the screening colonoscopies, which this test actually not only gives us the ability to screen, look for polyps, but actually gives us the ability to take those polyps off.
Bingo.
Which unfortunately with the stool test, any positive stool test needs to be followed by a colonoscopy for the screening to be successful. If you can do all the screening tests you want by stool, but if they keep coming back positive, there's blood, that's not gonna do you any good. It needs to be followed by a colonoscopy so we can look for these polyps, we can look for the bleeding. That's correct.
Nice. So let's talk about, and I think it's good for the audience just to hear of personal experiences on the show. I had my first colonoscopy, I'm 55, so 5 years ago. And I did the Cologuard test this year, so there was nothing was in there, it was clean. Wait 10 years, but to me, I'm like, I want to know. So my doctor said, would you like to do a Cologuard test? I'm like, I would rather do that than wait another 5 years for anything. And again, super easy. You follow instructions at home. You literally mail it in.
Yeah.
And so again, if it just frightens you for whatever reason, there are other ways. This, without question, and this is me as a layperson saying it, colonoscopy is the way to go because if there's anything in there, it's taken out. It's during the screening. You don't even know it. Like you said, you're asleep anyway. Things are clean, and if you need further treatment, there you go.
Absolutely.
But I wanted to see if you had anything to add on that, on any of the other screenings.
I think patients also need to be aware of a syndrome called Lynch syndrome. Lynch syndrome is where families have an exaggerated propensity for not just colon cancer, but uterine, breast, ovarian, lung. There's a family, and they have chromosomal abnormalities. And these patients need to be screened much earlier. And therefore, there could be families where you might do the Cologuard test or other tests in between their frequent colonoscopies, so you can stay on top of them.
Right.
Where they've got a bad family history, you know it's going to happen eventually. We do colonoscopies every 2 to 3 years in some families, but we might want to do a blood test also in between.
Nice, exactly.
But the colonoscopy, Catherine, the way to look upon this is, at my age, I'm worried about grandchildren. That this is an investment in your future. For an hour or so getting a colonoscopy, you can sleep peacefully at night for the next 5 to 10 years and know that there's no chance that this Cologuard blood test may be positive 1 week and negative the next.
Right.
We looked up there is nothing there. That's a great psychological feeling and a great investment in your future. I have time. I can look at other problems, look after my other medical problems.
Agreed, completely agreed. We have a question here from the audience, great question. So I'm assuming this person has had a colonoscopy. If a patient has developed pockets in the colon, are they guaranteed to get diverticulitis? And then from there, what are chances of colon cancer, development of polyps? So pockets are different than polyps, but we haven't talked about that yet. So who would like to address that one?
Yeah, I can.
Okay,
take it.
excellent, go for it.
So what he means about pockets is diverticulosis. It is called disease called diverticulosis. It comes from the tear and wear of the colon with aging, and it is common in most of the people above 60. Around 50% of people above 60 has diverticulosis, and about almost everybody above 80 has diverticulosis. And not everyone has diverticulosis, get diverticulitis, what's inflammation of the diverticuli. Around 5%.
About
or less.
5%, that's it.
That's
Or
very
less.
small
That's a
number.
small number.
Very
Yeah,
Yeah, it is
okay.
many people, many of us has diverticulosis and go without any symptoms.
So here's a question, how do you know?
So-
Is the only way you can find out by doing a colonoscopy? If you have pockets in the colon, how would you know that? Are there symptoms? And then they come to you and test. What are the tests for that?
Yeah, so usually if it is diverticulosis with no inflammation, patient doesn't feel it. Some people get constipation, some constipated. Some people, when they are doing CAT scan or imaging for any reason, they found it. But most of the people don't feel it. The only symptoms come with it, maybe constipation.
Okay.
So, but when it has complication like bleeding or inflammation called diverticulitis, people start to have symptoms. If you have diverticulitis, you will have pain in the area in lower abdomen. Some people get fever, and some people get bleeding. So here you need to see a doctor, and he may get some imaging.
Okay.
And treatment is usually easy. Some antibiotic is in the vein or in the mouth for a few days, and most of the time it resolves. Few cases or few percent of people get complication of diverticulitis. So
Now
it is
is-
a very benign disease.
Okay.
People shouldn't worry about it.
Yes, Dr. McCollum?
About 3% also bleed. So there's two different careers. You can either bleed or have an attack of diverticulitis, both rare, 3 or 4%. Essentially, everyone's got diverticulosis over the age of 40. And it's important to tell the patient, this is diverticulosis, not itis,
Itis,
because often
right.
it's misinterpreted, and they go around telling you, gee, my doctor told me I have diverticulitis. No, this is osis. It's like arthritis of the joints. You've been passing stools for 20, 30, 40 years. The bowel's been squeezing, and little pockets, little cul-de-sacs
Right.
develop. It's normal.
Right.
It's normal. And diverticulum that are big may go into a blood vessel and bleed. The diverticuli that are small trap stool, and that stool could lead to an infection
Okay.
called diverticulitis.
Okay.
But
It's like if there's little ulcers within the colon. I guess I think I've heard it explained like that in the
Yeah.
past.
wear and tear.
Yeah,
It's
just
wear and tear. We all
Yeah.
have it. Only about 3% ever get into trouble.
Okay.
And to complete the answer for the one who called, there is no correlation or association between diverticulosis and colon cancer.
Okay.
So there is many studies were done, and
It's
there
almost
is
like there's a pocket versus a polyp. you
yeah,
know,
the
complete
polyp is a
opposite.
growth. The pocket is a just outpouching of the colon wall.
So let's talk about risks. I know that we talked about Lynch syndrome, but in general, and Dr. Robles, I'm going to throw this your way.
Sure.
What are some risks in general? Genetics are one.
Yeah,
but
for sure.
Diets, genetics, diet, etc.
You know, we speak a lot about genetics. We bring it up, but you know, I think it's the best way is to separate them into modifiable. You know, those risk factors that we can change ourselves, or non-modifiable, those risk factors that unfortunately we can't change. So the modifiable risk factors, there's been studies, and about 55% of all the cancers of colon cancer have been attributed to a modifiable risk factor. So it's definitely a very important topic here for risk. Now, what are these? Well, being obese, being overweight. Now, this link is a little bit stronger even in men. Smoking. But as usual, smoking has been associated with multiple types of cancer.
Right, right.
Heavy alcohol consumption. When I mean heavy, that's just 2 drinks for men and 1 drink for women. So it's not even that much. A diet high in red meats, cooking your meats in very high temperature, or eating a diet that's low in fiber. Now, for the non-modifiable, these are things that we cannot change. This includes age. You know, unfortunately, colon cancer correlates with age.
Right.
Inflammatory bowel disease, which is like Crohn's disease, ulcerative colitis. Now, these are
Yes.
conditions that there's a constant state of inflammation in the colon. And with inflammation, the same way inflammation is bad for the heart, inflammation is bad for the colon. It can eventually result in the formation of polyps and transforming of those polyps into cancer. And like we said, the genetic, the hereditary type of cancers. Now, these only comprise about 5% of all the cancers. So 95% are what we call spontaneous, spontaneous type of cancers. And very importantly, family history. Family history of colon cancer, particularly first-degree relatives, your parents, siblings, or even a child. Why is this the case? Well, you know, it could be some inherited type of genes, could be a shared environment that can put you at risk for colon cancer. And of course, you know, people who have a family history have different screening guidelines than what we have been discussing.
Yeah, I say the new kid on the block, which is out there and everyone's going to try to blame it at some point, is the microbiota.
I totally was going to ask about that because that's something, that's like the pill of the day, right?
All
Or
those
the pill of the
billions
week or
of
the
bugs
month.
in your colon.
Right.
Are you different from me? Well, yeah, you may have a different personality. You may be more nervous. You may be more relaxed.
Right.
We blame it on everything from autism to depression. But it probably does play a role right there in the colon,
Right.
where it's contacting food and the lining, the skin of your mucosa.
So to be clear, these are the bacteria that we naturally have in our guts anyway.
Because although the diet is interesting, you know, I got a family full of vegetarians, and I still delight in telling them, you know, there's no data yet that vegetarians are spared from colon cancer. It's not a straightforward story. I'm sure you're healthier, you're fitter, all that, sure, but it's not that straightforward. So there's microbiota, there's family history, there's all these other issues which play into diet.
Exactly.
Obesity is getting a lot of press lately because everyone blames everything on obesity, but it's getting a lot of press lately in these early colon cancer patients under 45. There seems to be a trend towards obesity in those patients.
That's correct.
And for the most part, depending on a person's medical condition, I think these are things that it's nice to bring these up during this program because they're lifestyle changes. You know, if it's possible, I guess I realize that some people don't. It's not just a lifestyle change, but in general, when we're talking about upkeep, and if you don't mind, let's throw out fiber. Again, I'm throwing out to anybody. You can mix it up in your drink. You can get it by food. It's always better by food. But who wants to take on fiber and what the best things to eat would be? Dr. Robles?
Sure.
Yeah.
So, go ahead.
Dr. El-Hanafi. Dr. Dr. Robles.
So eating healthy is important for your colon health. So to keep your colon and bowel movement healthy, eat more fibers. Eat vegetable.
So what type of fibers matter more? Because you've got people that look at whole wheat bread, and then you have people that look at the vegetables, and you have people that, well, I'm just going to put a spoonful in my juice or whatever.
Any fibers, it make your colon health better.
Okay.
So it regulates your bowel movement, and your colon will be moving smoothly, and you will have bowel movement every day or every other day, and it also regulates your microbiota and the healthy bacteria in your colon. So it is always to eat healthy, drink a lot of water, keep yourself hydrated, exercise as much as you can, and if you see any alarm picture like bleeding, constipation, abdominal pain, weight loss, fatigue, seek medical help.
Right.
See your doctor, and he will advise you what will be the next step.
So in general with gastro health, and I'm thinking about, we mentioned the word antibiotics earlier. Say somebody does have diverticulitis, say I might even saying it wrong, but there are issues and there is an infection, we need to clear that out, so they're on antibiotics for an amount of time. And so the beautiful biology that happens in the system, and Dr. McCollum, I'll have you take that, there's a way to kind of get you back on track. Often your body just gets back on track. Sometimes there's a little bit of help you can give your body after antibiotics. What are some of the questions that you've had from patients?
It's true. We preach the role of probiotics to try to restore balance. You're out of balance. Certain organisms have become dominant, and we're trying to bring you back into a symbiosis. So we talk about probiotics as being very important. Not always a lot of data on it, but we certainly all believe in them. We know if antibiotics can lead to very dominant bacteria, as in Clostridium difficile. diarrhea can caused by antibiotics, which can be even very, very serious.
Right, right.
So, and then there's data that, you know, antibiotics in children, antibiotics here and there during your life, are you more prone to colon cancer? So that people try to link the fact that your microbiota have been changed, and you've been exposed to more inhibitory or more changeable bacteria from the antibiotics, and some bacteria become dominant. And so antibiotics are definitely in the picture, and that's why we try to minimize them in general, as far as being not too aggressive.
And I like the fact that we're bringing this up too, and not related to diverticulitis. Sometimes the end-all cure in my days growing up is like, oh, we'll get some antibiotics. And I feel that doctors in the last decade or so is like, you know what, if you don't need an antibiotic, don't take it. It was so easy to go to Juarez in the years past, just get antibiotics because I have a sore throat, antibiotics. So this would be one of those things too, that as an educational program, let's not take antibiotics unless you really, you know, there's a virus versus an infection. Very different things. I don't know if we want to talk about that, but what I do want to do before we start, because I think we're about 18 minutes out, but I want to talk about treatments. Some, and Dr. Robles, you got pointed at. Dr. El Hanafi, you got pointed at too. So we can talk about different degrees of colon cancer. Let's start there. And then talk about some of the small degrees or less invasive degrees, and then go from there. Who would like to start?
So I can start here. So the aim of colonoscopy is to find polyps. These polyps, if are not removed, has a potential to become cancer. So we can move small and large polyps. We have a lot of tools to remove that. So, and also we detect early cancer.
Gracie, if we can, sorry, my apologies.
Yeah, go ahead.
I'm going to see if we can put up the screens. If is there a number on there that you'd like to show to people? The numbers are underneath the
we can start. We can start with one.
Oh, good. We'll start with number one. We've got some really awesome pictures for you.
Yeah.
If you're squeamish, keep watching because you need to know
So
this stuff.
this is a normal colonoscopy. This is what we all look to see. So clean, normal colonoscopy. This is actually one of the colonoscopy we did with Dr. Robles. So it is really the target to see this thing. So if we go to the next,
that's a good cleanse right there.
Very good cleanse.
Yeah.
If you see here in the right of the screen, there is a little bit growth there. This is a polyp, small polyp. It is easy to remove by endoscopy, and we have a lot of tools to remove that. If you go to the next slide, so the polyp is removed, and we removed it by snare. This tool we have here.
And is that cauterized there?
This is cauterized.
Okay, so it's burned a little bit, the tissue. Okay, good.
Exactly. So we don't leave it there. If we go to the next, so this is a clip. This is what we meant. So you close the area, put a clip to seal it, and don't allow future bleeding or perforation. This is small polyp. It will not bleed or perforate, but to make it secure and to have peace of mind, patient go safely home. So if you go to the next one, this is larger polyp. So this also we're able to remove it by endoscopy. So if we go to the next one.
He's pretty big, yeah.
This is a polyp removed by snare.
Okay.
And thanks to Dr. Robles, he prepared this picture. This is what we do every day. We remove a lot of polyps like that. If this polyp was not removed, with time, it will become cancer.
Well, that's at least a centimeter.
That's at least a centimeter
we start
there.
to worry when we get over a centimeter. That's sort of the magic.
So the earlier you do your colonoscopy, the easier we remove the polyp.
So is this a clipping here, or is this the lasso removal?
This is the lasso.
This is the lasso.
Yes.
This is the one we have here, which is cut the polyp at the base.
Okay.
Then if you go to the next one, so this is the cancer. This is what we don't want to see. So we do a lot of colonoscopy, and we found this thing. People come late for screening, so we found cancer. So the treatment is totally different if you find the cancer in early stages from late stages.
Right.
So the earlier, the better outcome. So this is the target of colonoscopy. This is the beauty of screening, that we discover if there is a problem, we can treat it better, and the outcome is usually better.
Okay. Yeah.
So if you go to the next picture, so this is another type of cancer.
Wow.
It closes the lumen and causes constipation or bleeding. So whenever you have constipation or a change in your bowel habits or your change in the caliber of your stool, there is something abnormal there. There is something you need to be checked.
So there's a lot going on there. If you can explain the yellow on the left, the white on the bottom there, I see the bleeding.
Yeah.
And in the back there, the discoloration, you know, the nice healthy pink, and then a discoloration in the back.
So this is a cancer. So this is a mass which taken all the circumference of all the lumen of the colon. So we are looking to this mass by a camera. What's in the end of this picture in the center is the rest of the colon, is the lumen, the black thing
I
there.
see. Okay.
And the bleeding is due to our manipulation and biopsy. So what the yellow thing is just a stool, and this is a tissue fragment from the
Okay.
cancer.
I see.
So this patient, I remember, came with bleeding and constipation.
Wow.
So we have to do colonoscopy, and we found this mass. We were able to biopsy. If you go to the next slide, so we are biopsying the cancer, and we send it to pathology. They will let us know if this is cancer or not, but it looks like cancer, and what type of cancer, do some gene studies, and then we send patient for treatment. Either get surgery or chemotherapy or radiation based on the site, or chemoradiation before, or so first we have to make sure the cancer didn't spread outside the colon, because it is totally different, the treatment is totally different. If it is spread out outside the colon, or it is limited to the colon.
And what kind of testing do you do to see if it has spread?
Well, Dr. Roberts can review that,
Yeah.
the CAT
So-
scans and the MRIs.
yeah, so-
Why don't you give us an update on that?
So we typically do a CT scan of the abdomen to look for any spread of the cancer, or whether it's just within the colon. We do a CT scan of the chest as well to see if there's any involvement of any nodules, any what we call metastatic disease into the lungs. And now we do this because treatment is going to vary. Treatment could be either surgical resection if the cancer is just localized in the colon, or it can be surgery and chemotherapy if it's maybe penetrated a little bit more of the bowel wall. Now for cancer, what we call late stage metastatic colon cancer, which unfortunately has the higher mortality, it's gone to other areas of the body. Unfortunately, we're limiting what we do there. It's mostly palliative chemotherapy, immunotherapy.
Which is why you have to get your colonoscopy.
And just want to emphasize, I
Right.
think that's the most important thing here of this discussion is that early onset colon cancer, if caught early, has way more favorable prognosis, could be
Right,
cured.
right.
The thing is, it does not cause symptoms. It's why you need to get screened. It's why it's so important to get screened. So.
Nicely said. And if I know certain cancers naturally go to certain organs. Colon cancers, does it have a favorite organ or two that it goes to first?
It likes the liver.
It likes the liver.
It likes the liver.
Lymph nodes
Okay.
next to your colon first as well, but that's often good news. They're often confined. But the liver is a bad sign that something has seriously moved into the bloodstream and lymphatics, and it's a challenge. But patients with liver metastases can do well. Sometimes they do well on chemotherapy, and then the lesions can be shrunk and removed.
So I got here some other questions from the
Right.
audience. I know we're talking specifically about colonoscopy. We talked a little bit about Cologuard. We have several questions here. One of the questions is there another imaging process that can be done aside from a colonoscopy? Yes, but no, not in something taken away. But I'd like to respect that question because it says here, why do doctors want patients to get colonoscopy just because of the age? I'm reading this cold, even if they don't have any symptoms. Exactly what you said. You know, percentage of colonoscopy is not. So that's the point. There are seldom, if any, symptoms. So get the screening first. And so here's the other question: other images aside from colonoscopy?
Yes.
Yes.
Go ahead.
There is a CT colonography. This is a CT which can detect polyps,
Okay.
but it mainly detects large polyps. It can
So if
miss
it's a smaller polyp, most
smaller
likely to
polyp
miss it.
can be missed.
Okay.
It is also a test when there is a polyp. You need a colonoscopy to remove the polyp. So and it will require bowel prep, similar to the colonoscopy, to make the colon clean to be able for the radiologist
Right.
to see the polyps.
So do the colonoscopy anyway.
So to be honest, do anything.
Yeah.
Do any test.
Right.
So any test is better than nothing.
Right.
So just do what's available for you, and better than going with no screening test. Stool test is okay. CT colonography is okay. But if any of them become positive, you will need colonoscopy.
Right.
So do what's available for you. Do whatever your doctor recommend for you. Anything will be helpful and will protect you.
Okay.
The evolving area is a blood test. You know, everyone would like to get their blood test, so to speak, and it's a hot ticket, whether it's pancreas or whether it's the colon. And
So a regular blood test?
Yeah,
there's
a chemical called carcinoembryonic antigen, CEA, carcinoembryonic antigen, which is definitely up when you have cancer. But how early and what is the sort of earliest increase that you would take if you were to do it every 5 years? Could you predict when I should get that colonoscopy, or should I be more aggressive? But everyone's looking for a blood test.
Right.
Yeah. Because
So when
that
you're
would
saying
be,
this, are you looking at other cancers as well?
Yes,
Because you have that cancer antigen in you.
right.
Interesting. I was not aware of that. That's something relative. We'll have to talk about that again.
That's a hot ticket.
Yeah. Okay. Again, there's like the test of the day. I'd like to talk about recurrence really quick. So let's say somebody has had everything's treated. Let's say they've had surgery, they've had chemotherapy. So part of the colon is gone, chemotherapy, everything. And now, how often should that person be tested, and what tests should they have?
So after diagnosis of colon cancer, pretty much your screening goes back. It's no longer called screening; it's actually called surveillance, meaning that there's already a history of something being found. And colonoscopy is pretty much the only method. So after surgical resection, let's say they removed the tumor, they connected your bowels together, great news, things are great. We recommend doing another colonoscopy in 1 year after that surgical intervention, just to make sure there's no recurrence, just to make sure there's nothing crazy else is going on in the colon.
Right.
After that 1 year, your next colonoscopy, if everything is normal, it's in a 3-year time period. That's normal. From then on, it's every 5 years. Just for the fact that once you develop colon cancer, there's something in your genes. Cannot specifically tell which gene, but there's something in the genes that's maybe promoting the development of colon cancer. So we're a little bit more aggressive in our screening, surveillance type of examinations.
I know me, I'd go back every year. But that's me. You know, it's not a paranoia thing. It's like this is something we really want to know. We've got about 5 minutes before the end of the show, so I just want to double check with all of you and see that we haven't missed anything that you wanted to get across yet tonight. And I'm going to start with you.
Well, I'd refer you to Dr. Alan Haffer, because we need to go over your polyps. You know, you saw us take them all out, and you saw us show the nice pictures, but
Now where do they go?
you're under the microscope. You know, you've gone beyond a pimple or beyond a little mole. We found a polyp, and you've got to plug into a very long-term program.
Yes. So colon cancer, I want to echo that colon cancer is one of the cancer, as you said in the beginning, which can be prevented.
Right.
And we have the tools to prevent it. We can remove small polyps and very large polyps by endoscopy. We have a lot of techniques, a lot of tools to help us to remove it by endoscopy. And if we are not able to remove it by endoscopy, we can remove it by surgery if it is not removable, and it will not turn to be cancer, because it is different game if you have cancer or you have large advanced polyp. So we just encourage everybody to check, get a screening test, whatever modality, and if he's able to get colonoscopy, this is great, this is the best modality. But if he's not able to get colonoscopy, get some other test and seek medical help. In El Paso, we have a lot of good gastroenterologists who can do colonoscopy and remove polyps. And it is not only the gastroenterologist, it is the team, and we are proud in University Medical Center in Texas Tech to have a great team who has a lot of expertise in removing large polyps and do advanced procedure. So I just wanted to shout to them and say thanks to all the help. Last year we did around 4,000 to 5,000 colonoscopy in our unit.
Goodness gracious, wow, good for you.
But once we found the polyp, Dr. Roberts also tell you, you're plugged in for life. You know, this is not God. No, thank God. You know, it's over. This is the beginning of a career. So the polyp is a marker that you're under the microscope. How often do we do it, and what do we try to do?
Yeah, so we talked earlier about the change in screening age. So there's actually been a change in how often we screen someone, whether after we find a polyp. So depending on the size of the polyp, depending on how many polyps we find, will determine when your next colonoscopy will be. Example, we find 2 polyps. You know, they're small, 8 millimeters. They're not showing any sort of malignancy, cancer. Well, we can repeat one in 7 to 10 years. Now we find more polyps. We find 5 polyps. We'll recommend screening between 3 to 5 years. And I just want to finally just emphasize the point that colon cancer again is very treatable if caught early, early stage.
Yeah.
Most importantly, we prevent it. 5-year survival for cancer that is caught early is about 90%. It's good. But you know what? 5-year survival of that cancer that's caught when it's already gone to other organs, I mean, we're talking about 10. 14%. So it's important, get screened, get screened, get screened.
You want to prevent the spread.
Any adherence to any screening modality is beneficial. Colonoscopy, stool test, just adhere to one screening modality. Yes.
Right. And if the test comes out a little funny, go for the colonoscopy.
Absolutely.
Afterwards.
Yeah,
Yes, Dr.
combining both, genders, male and female. This is the commonest. We're not trying to outcompete breasts with women or along with men, but combining everyone. It's up there.
Yeah.
And it's low-hanging fruit, treatable and diagnosable.
Right.
And I think we just need to preach that gospel. I've seen a lot of change in my own personal approach. I talk to patients much more about when was your last colonoscopy, just as much as I talk about how's your tummy.
Good for you. At parties, you do that. 4th of July party. Hey, do you have a colonoscopy yet? Yeah. It's true.
Good.
We are about to wrap up the show, and Dr. McCollum, I'm gonna steal this from you for a moment. And if we can get this camera on. There are a couple of things at the El Paso County Medical Society. I have to give them a huge shout out. This is a peer-reviewed periodical that is written once every 3 months, I understand.
Exactly.
This is 45 years in the making. So this is the 45th anniversary of doing the El Paso Physician in this periodical, in this publication. This show is 25 years old, and the El Paso County Medical Society and Patsy Slaughter and Elsa Shapiro never get a high five, so they get a high five today because they're the ones that make all of this happen. Also, Melissa Huddleston, who is answering all of our phones this evening, and she's sending along questions. Thank you so much, Melissa, and it's great because that's what if I'm looking at my phone, that's what I'm doing. Melissa's the one that's doing that. Dr. McCollum, every now and again, you jump in and you help sponsor programs. And that's a big deal. Not a lot of doctors do that. So thank you for that. And again, I want to say thank you to Dr. Robles and Dr. El Hanafi. You guys have been great. And it's always a dance to do this show, right? Trying to figure out if it's a tango or a waltz, and you've done it quite well. But this is colon cancer awareness. Last month was the month, but really every month is a month to save your life. We joked at the beginning of the show that a colonoscopy is one of the greatest gifts you can give yourself. There's a little bit of prep. Don't eat steak 24 hours ahead of time. I get it. And then the prep won't be so bad. So thank you so much for being here. I'm Catherine Berg, and you've been watching the El Paso Physician.